Okay. Good morning, everyone. And there's a caveat to this presentation. And the quality of this presentation rests on the foundation of 3 hours sleep, as I had the opportunity of being stranded at Dulles Airport last night. And at one point in time, there was a question whether I was going to make it here or not. But so now that if I slur my words, I've asked James to pull me off the stage. And now that that's been set aside, we're all in this together. What I'm going to be talking about here is, while national attention has recently focused on the inadequacies of terminal care in hospitals and the community, little attention has been placed in the unique needs of the terminally ill older adult in long-term care homes or facilities. And so over the next 20 minutes or so, we're going to do a walkabout. And when I say walkabout, I'm going to be sort of sharing with you what are some of the initiatives and practices in different jurisdictions which have been engaged to address this issue. And to start this walkabout, we'll start here. Despite the fact that death occurs predominantly in older adults, the current practice of palliative care has been developed in the developed countries, has been critiqued as being sort of targeted towards a younger population diagnosed with cancer. In the case of palliative care for the older adult, it may concern a primary disease such as cancer. In fact, cancer usually presents most frequently in those individuals who are 60 years and above. However, that individual will be accompanied with multiple comorbidities, which would include dementia, incontinence, sensory deficits that require attention in conjunction with common terminal symptoms such as pain, nausea, and shortness of breath. On the other hand, a younger patient may die from one disease, and the period of care can be a matter of months. So we're really talking about two very different populations. And as I said, the critique is one which has largely been, for palliative care, as it's been traditionally described, is for the younger population, cancer focused. So we have an issue there. So you'll probably recognize these bullets, and in terms of issues regarding end-of-life care, or care the dying. What we do see in the literature, and for those of you who are practitioners in this sector may recognize, is these are the typical issues. Pain assessment and management, limited physician involvement. There was a classic article that was produced by Joan Tenno in the United States a few years ago that described these two primary providers in the facility and physicians as ships passing in the night. Of course, there are also generic issues that plague long-term care, which you'll see under staffing, which speaks to the level and mix of staff that are present in these facilities. And of course, educational needs among staff with respect to caring for individuals with complex needs who are approaching the end of life. The use of advanced care planning, whether it's used, how is it used. Access to specialized care. And this speaks to the relationship. If we recognize this as a sector of care which has historically been marginalized from mainstream health social care, one of the considerations is what's its relationship to other aspects of care. And of course, there's hospital transfers. This is sort of the mantra which we hear these days in terms of unnecessary emergency EDs and hospitalizations. Communication issues, which involves between recognizing that long-term care is essentially a hierarchical environment where the care is actually provided by personal support workers, but can be quite restricted either organizationally or or by themselves in terms of what they share, how they talk to family members. Communication can be problematic between staff and families, and certainly among staff themselves. And of course, getting back to this notion of external relationships. So the litany of issues that certainly the research evidence documents is quite extensive, and also what we hear from practitioners in the field. That said, what we do have to recognize is that caring for the dying or long-term care rests on a strong foundation. What we have in long-term care are sort of intimate relationships for the care. These are long-term relationships. They're intimate relationships. Staff develop emotional relationships with these individuals. And long-term care homes, in actual fact, have a tradition for providing care to the terminally ill. So while we sort of can catalog some of the challenges that long-term care homes are are dealing with, we also have to recognize its assets or strengths as well. So this slide here is really sort of the stage for this presentation. And when I said walkabout, literally that's what we're going to be doing, is a walkabout. So what I'm going to do briefly and at a high level is we're going to be talking about some of the initiatives which have been pursued in different jurisdictions. Recently, The Economist published a report where they actually examined 40 countries internationally and assessed their capacity in providing quality end-of-life care. The outcome of that ranking was that the United Kingdom and Australia came first and second, and the United States and Canada were ranked ninth. What's interesting there is that the palliative care agenda in the UK and Australia were quite similar. In a sense, they were national initiatives which spread out. And with respect to the United States and Canada, we actually have quite fragmented systems of care. In fact, in Canada, we could argue it's balkanized. And I think that so when we go through these particular slides, I think that will probably, one of the underpinnings with respect to the capacity of the state or a community to engage in providing quality care of a vulnerable population is the organization and delivery of its political structure and how that supports these types of initiatives. So with respect to these four jurisdictions, I'm giving you a bit of you can sort of see what we're going to be talking about in the next few minutes. So we're going to start off with the United Kingdom. And what we have here, I got to find my notes so we don't lose myself or you. It's the Gold Standards Framework. Some of you may recognize this, and was originally developed in 2000 to improve primary palliative care within the primary care setting. So over the last 9 years, what has happened, it's starting as a grassroots movement in the UK. It's expanded, become a national initiative funded by the National Health Services. And what you see here is the logo and also sort of where those sort of central thrusts are, both in terms of primary care and also, for the reason why we're here today, in the UK they call care homes. And the gold standard rolled out into care homes in 2004 and involves a structured training program as well as a formalized accreditation process. So that said, let's take a look at the objectives of the gold standard framework are as such: improving the quality of care for people nearing the end of life, improving collaboration between care homes and GPs or the community, strengthening those external relationships, and reducing hospitalization in the last stages of life. The goals for the framework actually takes a sort of a what would be described as I've just lost my notes already, a multi-dimensional framework. And this smudge slide is going to try to share that with you. The nodes of emphasis would be around communication, coordination, control of symptoms, continuity of care, continued learning, care support, and care of the dying pathway. What's really essential with respect to the gold standards framework is that it recognizes that training and education is insufficient on its own to produce a culture change within the care home to improve care for the dying. So they recognize that while training and education is important in terms of targeting the providers, they also have to sort of address the processes of care within the organization and also the structures of care as well. In actual fact, what's really important with respect to the gold standard frameworks, and I think which will be a take-home message from this particular presentation, is that it's important to avoid a silo effect. While this presentation is focusing on sort of palliative care or caring for the dying resident, what we're really talking about is really caring for the individual in that life journey, that living, dying interval while they're in long-term care. And we're talking about quality improvement in general. And there's a sense of artificiality by sort of putting an sort of undue emphasis at the end of life. So that's really sort of the punch to the presentation. But I do have more slides to share with you. So as I said, the gold standard framework actually has a 3-stage process. And from my understanding of the readings and discussions with colleagues in the UK, the actual intervention itself can be customized to suit the context of the facility itself in terms of what's provided in there. But there are 3 formal stages, that being preparation, as you can see here, training, and ultimately accreditation. And embedded in that is three products which they introduce. There is three tools. There is what's called a structured care pathway for the last days of life, which it's called the Liverpool pathway, which is used in the UK and is actually being picked up in Australia as well. Originally, it was intended for a cancer population in the community. It's now being adapted for long-term care settings. The second piece that they've introduced there is a framework for really prognosticating who will be dying, or sort of trying to get an estimate in terms of where their trajectory is. It's called the ABCD scale. And each of those letters represent days, weeks versus months. And also there's a third piece is an advanced care planning booklet. So those are the three key tools within this particular initiative that is promoted within the gold standard framework. Yoked to that, of course, is training and education, the use of an outside facilitator to move that, who works with champions within that facility to move this particular agenda forward. The evidence, in actual fact, in the last couple of years, they're starting to produce some outcomes with respect to the evaluation work with respect to the gold standards framework in this environment. And what they're determining is that it's proving effective in the context of, let's see here, a significant decrease in crisis hospital admissions and a decrease in hospital deaths. One of the goals of the gold standards frameworks in terms of allowing death to occur in the home. Now, what's interesting, in actual fact, this national project has actually involved 1,000 care homes in the UK, and approximately 300 to 400 care homes in the UK go through this formal accreditation process where they're evaluated with respect to how their level of compliance or adherence or success with the gold standard framework. And when you check their website out, you'll see the teams holding their plaques, which they can sort of put a little gold plaque, which they can put into their institution. So it's formalized to that extent. And as you can see, the diffusion is quite extensive with respect to the long-term care sector in the UK. So we're going to jump across to the other side of the world, and we're going to speak to the issue of Australia. In Australia, they've actually, I think it was around, they've developed, I have a year here, but I didn't write it down, but I think it was around the early 2000s. They developed what you see here, guidelines for a palliative approach in residential aged care. There's approximately 3,000 residential care homes in Australia, and recognizing that this end-of-life care, the treatment of dying long-term care was a significant issue. They put this particular set of guidelines together. They're described as evidence-based, and these are the various chapters within these guidelines that they speak to. So it's quite comprehensive. I'll just let you sort of soak that in. As you can see from the various chapters, it is rather a sort of comprehensive or holistic approach to caring for the resident, including sort of Aboriginal or First Nations community as described here in Canada. Now, but what's interesting here too, initiatives within Australia didn't rest with the development of the guidelines. They actually sort of